In a patient that does not have an oncogenic driver, the standard of care now is chemotherapy, and there are various options. The options vary based upon the histology of the cancer. Options are different in adenocarcinoma than they are in, say, squamous carcinoma. And then with the recent data that we've had over the past 3 months is, are you going to integrate immunotherapy? And I think we had several trials presented recently. The two prominent ones are Keynote 189 and Empower 150, which took the two FDA-approved chemotherapy platforms. In Keynote 189, it was carboplatin and pemetrexed. In Empower 150, it was the platform of carboplatin, paclitaxel, and bevacizumab. Again, two FDA-approved regimens, and grafted onto them in a phase 3 setting immunotherapy. In the case of Keynote 189, it was pembrolizumab. In the case of Empower 150, it was atezolizumab. Both of those trials showed significant benefit in overall survival, progression-free survival, overall response rates, and durability of response. So these are two positive trials saying that whatever platform you're using, carboplatin, pemetrexed, or carboplatin, paclitaxel, and bevacizumab, the incorporation of immunotherapy in those regimens actually improves outcomes. Now, this gentleman, because of the history of intermittent hemoptysis, would not have been a candidate for bevacizumab because that's a absolute or relative contraindication to the use of that drug because of the risk of pulmonary hemorrhage. But he was a perfectly appropriate candidate for the chemotherapy platform of carboplatin, pemetrexed. He had no contraindications to immunotherapy. So in my opinion, he received the standard of care, state-of-the-art treatment recommendation, combining immunotherapy with that carboplatin-based doublet. When I initially discuss patient treatment options with the patient with stage 4 disease, I say that there are really 3 buckets of options. Targeted therapies. But in those patients with targeted therapies, you have to have a target. And we evaluate patients for the targets of EGFR mutations, BRAF mutations, ALK and ROS1 translocations, and there are other RET translocations, MET amplification or exon 14 skip mutations, HER2 alterations, NTRK alterations. There are a growing number of actionable oncogenic drivers that we treat. If you have a target, you use targeted therapy. So that's one bin, okay? The second bin are which patients may you treat with immunotherapy alone. And right now in my practice, in those patients that have very high staining for PD-L1, which is greater than 50%, I will use pembrolizumab as a single agent in the vast majority of those patients. In the remaining bin, we have patients that are appropriately treated with chemotherapy, and based upon, as I previously said, Keynote 189 and Empower 150, I now think that combining immunotherapy with those chemotherapy platforms is the appropriate treatment strategy at this point. This gentleman had adenocarcinoma, and so carboplatin, pemetrexed, as well as carboplatin, paclitaxel, and bevacizumab are two FDA-approved standards for the treatment of adenocarcinoma. Let's say he had squamous carcinoma. We had another trial, Keynote 407, as well as Empower 131, that were both positive, showing the benefit of adding immunotherapy to platinum taxane therapy in squamous histology patients. So both in squamous and non-squamous, we have integrated immunotherapy with our standard chemotherapy regimens based on overall survival benefit.